to the recording in progress. Welcome to the 2022 State of the Department presentation. Just a couple of announcements first. First, I want to welcome all faculty, all staff, all trainees, and any other people outside the department that have graced us with their presence. We really appreciate you coming. As of right now, so this is hybrid, so that people that couldn't come in person could still attend like we've been doing. So far, we have 80 other people on remote, so that's fantastic. Thank you for coming. There is a grab and go lunch in the atrium at the completion of of our day, or of this hour and a half. We planned this before we went yellow, so we are not going to be eating together today, but hopefully moving forward we'll be able to do that. But you do have a grab and go lunch at the end. And speaking of grab and go lunches and meeting in person, it's great to be in person. We are in COVID yellow for clinical areas, so we still wear masks. Well, anybody can wear a mask to feel comfortable. We absolutely wear masks delivering patient care or in public patient care areas, waiting rooms, lobbies, and the like. This also invites us to get back to work in person. And so I want to encourage team leaders, directors, bring your program meetings, your team meetings back in person to the degree that it makes sense. As I promised halfway through COVID, our attendance at Grand Rounds has been so robust. We've had 200 plus people come to Grand Rounds, every Grand Rounds, and it's because of access. So we went remote to increase patient access to care, but it also increases access to educational and departmental activities. So for our Grand Rounds, we will go forward always having a hybrid model. But again, for smaller departmental meetings and maybe ongoing faculty meetings, we'll try to meet in person. Today's format is a little bit different. You're used to having a 90-minute presentation with various sometimes various speakers talking with a full overview of all the accomplishments, individual recognition, et cetera, lots of slides. Today, because of our new dean that we've invited here, I'm only going to talk for 30 minutes with many fewer slides, a much higher overview. I'm not going to take the time to recognize each individual accomplishment or grant or publication or anything like that, but we will distribute the slides. We also have the annual departmental report that Dr. Gladwin has, but it has lots and lots of detail on all of the accomplishments in that, and we can certainly share that as well. So a little bit different. I'll talk for 30. I'm going to hand over the podium to Dean Gladwin then, who will talk to us about his vision and open it up for dialogue with faculty and staff. So we look forward to that. Here's our agenda: staff recognition, promotion, new faculty, a brief financial summary, highlights of our programs, diversity, research, education, and clinical. I'm going to swiftly review some FY23 priorities and direction, and then we will have Dr. Gladwin join in the program. So I want to start with recognizing and thanking our business administration team. We have a huge team in this department that supports everything we do. We can't do what we do clinically, research, or educationally without our support team. And here's a list, I think most of them, if not all of them. I also want to recognize our new business operations director, Winnie Wara. Winnie, are you here? Winnie, there you are. Thank you, Winnie. Congratulations. Really excited to have you on board. She's hit the ground running, but she's been with us for a little while, so she kind of knows the ropes, which is great. Thank you, Winnie. New faculty, we have 10 new faculty recently joining the department, 3 child and adolescent faculty, Marianne Booth, Deborah Heck, and Margaret Woodbury have joined us in the child and adolescent team. We have Andrew Colbreth. Andrew, I want to try to recognize people, and yet it just takes a lot of time. And actually, Dr. Gladwin can actually see you from where he sits. So over time, you'll get to know these folks. Adam Colbreth is a new PhD member of the faculty. We have Majed Haraj, who's new PhD researcher. We have Tamala McClam, who's a geriatric psychiatrist, joined us, I think, August 15th. Peter Fallon, who's a new PhD researcher in the Division of Psych Services Research. We have Dr. Sampaio and Van Remen, who are both graduates of our program and joined us September 1, and are going to be doing inpatient work and some outpatient work. We have Alicia Whitrova, part of the Division of Addictions, doing a lot of research work. And I think that covers it all. So 10 new faculty, welcome everyone. And we'll have more activities for you integrating as the next 6 months proceeds. Faculty promotions, we did have 5 faculty promotions. We had 2 assistant professor promotions, Dr. Sonia Bonzel at the MPRC and Dr. Julie Fields at the Midtown campus doing inpatient work. We have 3 associate professor promotions, Dr. Sarah Edwards, in our child and adolescent division, Dr. Kushalani, who's an adjunct education professor, and Elaine Weiner, associate professor again at the MPRC. Congratulations to all of you as well. Okay, just a quick, we had our July summary year in review for diversity. Occasionally I'm going to just fill in Dr. Gladwin so he knows sort of where we're at. 4 years ago, we started a huge program in diversity, equity, and inclusion that crosses education, research, and clinical work. A year after that, I hired our chief of diversity in the department, or promoted her. You'll see a picture of her in a minute. And we have had a very robust program with lots of volunteer participation across the department. It's been very, very impressive. Who are they now? We have champions in every division, every program. I'm not going to go through this list, but I do want to give a heartwarming thank you to the volunteerism and to the enthusiasm of this important work. And I really appreciate it. So thank you to everyone here. And then I just want to remind everyone, we always have a focus for every year. Dr. Anik Forrester, our chief of diversity, has highlighted for us that we're focusing on equity. And what does that mean? So whenever I ask somebody about equity, they always talk about salary or benefits, money. That is very important, very important. But it goes way beyond that, and it goes into realms that we all have the ability to influence. So equity relates to power. And to think about it in what we can do, think of the reverse. So inequity is really about systems and structures that get in the way of everybody participating in discussions around development, problem solving, and decision making. Equity requires access to process. And when you think about it, we all have process. We all have areas in our daily work where decisions are being made and we're problem solving. And so what I would ask each and every individual, in particular, anyone in a leadership role, when you're making a decision, when you're thinking about changing a process, think about the people that change is going to impact. Think about who should have a voice in expressing what they think about that change. Who can better inform you of the impact of that potential change and include them in the conversation. And so I just encourage everyone to think about that. I think if we all did that, it would make a big impact on a sense of equity in our department. A financial overview of the department. I'm moving very quickly because I really want to give Dr. Gladwin as much time as possible. So we've had again, a rock solid year financially. We had a total revenue of $64.9 million, with slightly under budget by 2%. We had an operating budget. It was a budget of $66 million and we saved 2.1%. So we came in at $64.5 million with a surplus of $360,000 of operating money. So if you take a look at our total FY22 operating budget of 65 million, 35 million is from grants and research grants and service grants and contracts. 10 million is from our physician service contract with the hospital system. 6.9, there's a typo there. This is 6.9 million is from the School of Medicine in various ways, and 2.7 million is through our collective practice plan. So we completed the fiscal year 11% ahead of the budgeted for collections. A nice look at the financial performance is to look at it by year, and you can see for total revenue here that we have had a steady increase in our total revenue. I'll say this probably more than once, Dr. Gladwin, most of our revenue is due to grants and contracts, as you could see in the summary in the slide before. So we came in at $65 million of revenue this year, and we're budgeted for a 22% growth of $74 million next year. But I want to point out that our IDX cash collections actually is lower. And if you take a look at pre-pandemic, we were about 3.4 million, and we have yet, and in fact, we're the lowest yet this in FY22. We have yet to get to reach our pre-pandemic IDX collections. And this is through our PA for professional services. Why is that? There's a number of reasons that is the case. One is our inpatient volume, which I'll talk about when I get to clinical summary, is down because of our bed capacity. A lot of our old units have double occupancy, but all through the past 3 years, we've been operating it with single occupancy. So it's cut our census in half, it's cut our pro fees in half. We also have enormous difficulties in the hospital in acute care, staffing beds. We've got a shortage of nurses and techs and social workers. And so if we can't staff the bed and provide the care safely, we can't put a patient in the bed. And that also impacts our revenue. Thirdly, even on the outpatient basis, we've had significant turnover and difficulty replacing. So all of that impacts, and we're still definitely impacted by the COVID numbers. So let me go on to the research highlights. I just want to again recognize and thank the leaders of the divisions and programs. Gloria Reeves is our vice chair of research. She's done a phenomenal job this year. And then the division directors, Melanie Bennett for the Division of Psych Services Research, Richard Goldberg for MyRec, Todd Gould for our Basic Science and Translational Lab in MSTF, Deanna Kelly for the MPRC, and our clinical divisions that do more of a lion's share of that type of work. Addictions under Eric Weintraub, I see Eric in the back, and child and adolescents, Sarah Edwards is our division director, Dr. Edwards. So what? Oh, there you are. So I'm going to thank all of you for really the work you do. And before I dive into the numbers for research, I would like to thank and highlight the success of the MPRC fundraiser, just out of curiosity. So this was kept low key because we were still in the middle of COVID. How many people here were aware of the silent auction fundraiser with NAMI that MPRC conducted? Okay, about 50%. That's great, or maybe a little bit more. That's terrific. If you didn't participate in the silent auction, you really lost out, because I came home with 5 items. And I think I need our Center for Problem Gambling, because I don't gamble. I don't do a slot machine, but boy, I got on that silent auction and I wasn't going to get beat. So I have a piece of Dr. Knight's work in my kitchen. I have 3 pieces in my office. Sonia Bonzel's vase with dendrites and neurons on it. It's fabulous. And when I had the chair of pharmacology in my office last week, Dr. McCarthy, she looked at the vase and said, well, there's neurons on that vase. I have Greg Elmar's gorgeous Hawaiian photograph in my office. So lovely stuff. It was a wild success. The staff and faculty and community of the MPRC pulled together. They had an on-site art display, but then they had a silent auction that went, I think, for about a week. So there's strategy in it. You know, you put in your bid and then you wait until an hour before the whole thing ends. So it was wildly successful. I cannot remember how much money they raised for NAMI, but it was something about $3,000 of all donated art. And there is a planning committee already convened for another one this year. So I encourage everyone to participate. Research summary overview. So in the Department of Psychiatry for FY22, we had $35 million worth of research grants and contracts. We're slated for 39 next year. We had a quick summary, $20.3 million in grants, 57 new grants were awarded in 22, 16 active R01s. We had a new K23, UH3, and R21. We did have a 6% growth in our research, and we're 21st on the Blue Ridge report, which it looks only at federal NIH funding. I think our goal for next year is to get to 20, back to 20, I should say. We were at 20 and we slid back to 21. I also want to point out that we had submitted 7 COVID-related grants for a projected $12 million of funding. And I threw this in at the last minute. Dr. Gladwin, I know you're interested in K awards, and I have an error here because there's actually 5 Ks in the department. We have a T32 out at MPRC with 2 trainees in it now. And I know that there's 3 more K applications going in June. So it's definitely an avenue that we are trying to take advantage of. This is really rapid fire, and I hope people aren't angry that I don't highlight. I'm really gonna I just highlighted a couple things about each research division. DPSR does a phenomenal job of collaboration. They collaborate with the VA, NIDA, College Park, probably every school on campus. They do a great job. They also, Dr. Gladwin, run the evaluation center actually for the state under the leadership of Doctors Goldman, Davis, and Bennett. They do have a BHA pilot to measure fidelity for first episode psychosis program. So they do great work. Dr. Bennett hired 2 new researchers, one last year, one this year. Dr. Peter Fallon was the one this year. MPRC, $11 million worth of grants this FY22. They had 40 new grant applications, 17 went to NIH, 11 new grants were funded, and 4 from NIH. We have the new K, Adam Colbreth, and then there's a whole list of, but it is not all inclusive and it's not everything they do, but a list just to highlight some of the accomplishments and stars of the MPRC, but everybody's a star at MPRC. Todd Gould's lab, again, basic science, done a great job of holding that team together. And we have a great partnership with epidemiology up on that floor, and it's really quite fun. And we hired Majed Haraz to broaden out our basic science in addiction research, and I'll talk more about that in a minute. Child adolescent, they are a robust division for doing lots of service grants and contracts. But Gloria Rees and Dr. Khanna in family medicine did get the FCC equipment grant of almost $1 million. And I can tell you what we did with that in a minute. But again, and we also, Dr. Gladwin wants you to know that we are the National Center for School Mental Health, and under the directions of Nancy Lieber and Sharon Hoover do a phenomenal job across the nation, but also within the city of Baltimore. So we provide mental health, school mental health services in 25 to 30 schools. It changes every fall a little bit for kids in elementary, middle, and high schools. They do great work. In the Division of Addiction Research, they had 5.99 million this year, dedicated to this year. They also, great collaborators, collaborate on three UMB care grants. They're working with the School of Nursing and the School of Social Work. They have a HRSA grant with the Department of Medicine and IHV. They collaborate with College Park, collaborate. So one of the things that I said to everybody 3 years ago when I stepped into this position, communicate, collaborate, and communicate, connect, communicate, and collaborate. And they do that naturally, and they've continued to do that. It's great. And we have a great relationship with the MIREC at the VA, and they had an additional $1 million worth of funding, and in jointly with school of medicine faculty. Our overview, we had 276 peer-reviewed journal articles, 7 book chapters, 1 book, 156 presentations, 10 posters, 35 media appearances on radio, TV, and print. And this is something, you know, I say to a lot, we need FaceTime. We need people to know who we are. We need to know, they need to know our experts. And one way to do that is to get us out in front. Now it's intimidating, and I know a lot of people avoid it, but I have seen some people that have been avoidant step up and shine. Dr. Edwards is one of them. Dr. Knight is another. Just done great jobs with representing us. And so Gloria Reeves, our Vice Chair of Research, has put together another training. So for people that want to just get comfortable on the do's and don'ts of doing a journal interview, a TV, you know, I've done a couple of those MTV interviews with Jeff Sulkins, and actually they turn out to be quite fun, and and he relaxes you. It's pretty nice. So it gives us FaceTime. We also were approached to be a part of the Washington Post wellness column. And we talked to them, we presented them with a whole list of ideas, and then they selected us to be experts in their mental health column. And I gave them the 10 top, what we thought were 10 top public interest articles based on everything you guys sent to me. So I put out, and by the way, thank you. I put out an email saying, who's interested in sharing in a Washington Post column some of your expertise on a topic that the general public can benefit from? And I got a robust response to my email. So I probably have 60 different faculty names with all of your topics. I've categorized it all, and I picked 10 that I thought would be really attractive. You don't want to overwhelm the editor. Of the 10, she picked 3 right off the bat. And so we've got some really interesting topics that are going to be written about, and we'll see how it goes from there. So again, FaceTime. Okay, department or division education highlights under the leadership of Mark Ehrenreich, Dr. Eric Reich. So Dr. Gladwin, we have one of the largest adult training programs in the country. We joggle between 2nd and 3rd. We have anywhere every year between 63 and 65 residents. We also have 5 fellowships, child and adolescent fellowship under Dr. Edwards. We have a psychiatry addiction and a medicine addiction fellowship, and we run both of those. A consultation liaison fellowship and a forensic, and we have a psychology intern program in collaboration with the VA, and that should be VA, not VAB. I apologize. Some of the accomplishments of our residents, I mean, just fantastic enthusiasm in the group. We had 14 national and local awards in the group in 22. We had 100% pass rate, which is about what we have almost every year. I think every year for the past maybe 10 years, Mark, is that right? Yep. The residents, in combination with some of the training faculty, published 22 papers, 24 presentations. We continue to get very high scores. And I want to acknowledge Marissa Flaherty. Melissa, are you here? There you are, Melissa. All right. She was selected as the best clinical faculty by the school, by the students graduating class of 2022. So congratulations. Okay, clinical updates. This could go on for hours. I'm just going to do a very high level summary. And one thing I'll have to help clarify for you, Dr. Gladwin, is that there is a difference between PA revenue and practice and work and rate regulated hospital clinics. So it's all jumbled up here. In our acute care, we had between the Midtown campus, 2 adult units, the downtown campus, and adult general and child, we had 1,300 admissions, discharges, hopefully both. Ambulatory billable visits. We just do an amazing amount of work, and everything is not included in this list. I'll get to that in a second. But Division of Addictions, 47,000 services were provided. That's high. The 44 is methadone dosing, so that does accumulate pretty quickly, but that team does an amazing job of providing services to daily methadone dosing to what, 700, 600 patients, yeah, a month. It's amazing. We had the only state-funded deaf addiction program. They served 738 services. Home health. Now, this is important. This is HARP. This is the upper payment program. So the Division of Addictions works with the Department of Medicine and ID specifically to provide primary care and medical care to individuals in the drug treatment program. They do wound care, they treat hepatitis. In fact, if this is still the case, Eric, you can let me know. We treat more hepatitis C in our addiction clinic than they do in the ID clinic. Is that still correct? Okay, well, it's been correct to date. Let me see. So, and primary care. So it's preventing unnecessary emergency visits. And this is the program that keeps our upper payment limit, which is an enhanced Medicaid reimbursement rate, coming to all of the departments, but it relies on 3 programs and ours is one of them. Okay, Division of Community Psychiatry, 52,000 visits. The Division of Community Psychiatry focuses on the delivery of care to individuals and their families with serious and persistent mental illness. And then all of our other ambulatory programs that we have billable services in, EAP, school mental health, CL, Gero, child, our adult day hospitals finally back up and running closer to budgeted volume, and our telemental health services, 6,500 visits for a total. We exceed 125,000 services delivered, visits delivered a year. What is not in here is all of our emergency room visits, because it gets jumbled up with the adult visits, the adult ED visits. It's hard to tease them out. And then a lot of the services that all of you deliver on grants that aren't billable services, but they can be patient care, or they can be education services, consultation services, lots and lots of programs that aren't even listed here, that aren't counted in these numbers, but this is billable visits. Most of these are hospital rate regulated charges, but I'll explain that to you later. Other clinical highlights very, very quickly. We continued in CL to maintain a 2-person fellowship. We used to only have 1 fellow, we have 2. And our integrated care model, which is having a psychiatrist on the team in shock trauma, has continued to expand and do well. Just a highlight from child and adolescent, Sharon Hoover did go on a trip to Poland and provided consultation and education in the management of 2.5 million Ukrainian refugee students. Very impressive. In addictions, Eric's team added another new mobile unit to Caroline County. Does that mean you have 2 units running? Yep, you got 2 units running. Great, great. So this is our efforts in providing addiction treatment to rural America, rural Maryland, not America, no Winnebagas, but okay. Eric and his team have also established our jail. MOUD stands for Medicine and Opioid Use Disorder. So we're giving Suboxone to inmates now in 2 counties, soon to be 3. And this helps inmates when they are released not completely relapse and then die of a fentanyl overdose, which is what we were seeing happening. Just amazing. And this is hard work because it's not easy to work with jail wardens, and there's not a lot of sympathy for these particular inmates, but Eric and his team have done a great job. We have 4 MAX programs. MAX is Maryland Addiction Consultation Service. It's state paid service. And we have 4 teams of that now, including DC heard about it and now they wanted it. So Eric expanded and created, it's not really MAX in DC, but it's DAX. It's DAX, right? Thank you. We also have sports psychiatry. So we provide services to the Orioles, the Ravens, College Park teams, and soon to come UMBC. Don Thompson is a big deliverer on that. Thank you, Don. Okay. Other clinical highlights, Ann Hackman, Dr. Hackman and Adams are greatly involved in GBRICS. You guys will hear about this on the news. It is the Greater Baltimore Regional Integrated Crisis System, $45 million over 5 years to stand up a mental health crisis system in our state covering 4 counties. So lots of work in that. Gero is expanding. Dr. Postalaki has joined Dr. Pete Crino in seeing adult patients with autism in his clinic. So that's a step we've never taken before, which is why I wanted to highlight it. We don't really specialize in autism. And he took that jump. And our teleprogram continues to grow. We're now expanding into Washington College, and we did buy 200 laptops and deploy them thanks to our IT team, Dave Flax and his team, 200 hotspots and 10-ish video carts for increased access. 10? Yeah, 16, sorry, underrated there. Congratulations to Dr. Chris Miller. Chris, you're here somewhere. I know you are. I saw you. There you are, Chris. Okay, he's our new medical director, and he hit the ground running with high expectations. And again, we're predominantly remote, but we always have on-site access to services. Gambling, this is what I needed with the silent auction. We have the Maryland Center for Excellence on Problem Gambling. It's funded every year, and it's been operating, I think, for at least 15 years. Is Rob here? Rob, I don't see him. He may be on remote. 10 years. Chris, thank you. I'm sorry, you're the medical director. And they are going to be our first column in the Washington Post around sports gambling. It's fall, it's NFL season. Everybody goes to their fantasy football. And so it's a great public eye catching, and that's what they look for. And employee assistance, we continue to provide great service. 2 more slides. Well, no, actually, I'm gonna, okay. This is a slide on community outreach. So I am always being asked by the School of Medicine, by the medical system, tell us what you do for community outreach. We have 147 faculty and staff that reach out not only to West Baltimore, but all of Maryland, providing services and resources. So I just wanted, we have that, we do it well, we continue to do it well. Our priorities very quickly. So Depression Treatment Center is something that I am absolutely dedicated to and committed to. Our department is behind in formalizing depression research and advanced treatments. And it's the advanced treatments that will get us to the research part. We need a model to address treatment-resistant depression and offer novel treatments. We need to hire a director of clinical depression research. We will encompass treatment-resistant neurocognitive disorders resulting in or appearing to present as depression. Dr. Morano is a big component of this as well. We will offer TMS, esketamine. We do ECT. We want to expand it and have more outpatient ECT. And eventually, I'd like to see us more involved in clinical trials within our clinical programs. We will explore, I already have the first meeting set up with Graham Woodward, the chair of neurosurgery, and his team, Alex K. I forget how to say his last name. It's very long. And we will explore with neurosurgery deep brain stimulation for treatment resistance. It would revolve around identifying patients and studying it initially. We are considering expansion into psilocybin treatment and studies, and We are also still considering a neuromodulation or fellowship or a neurocognitive fellowship. So lots going on there, lots of dedicated energy. We're reorganizing services in 701, and I have made financial commitment to stand this up. Second priority is the Women and Family Care Center. It will be a comprehensive evidence-based trauma-informed program that offers screening and evaluation for perinatal women, their unborn or newborn child, and young children and the rest of the family. We're going to focus on anxiety, depression, and addiction. Our team consists of child experts, Sarah Edwards, Kate Connor, Chris Welsh, myself. We'll have an initial West Baltimore focus. My hope is that this is a program that any woman and young family in Maryland would want to access. Eventually, we'll have remote access as well as on site. We've been meeting, and I just want to emphasize this will be a clinical program, an education program, so we will have trainees involved, and a research program. We will be able to conduct research. I already have a meeting with our new OB chair, who doesn't start till October, but her second week I'm on her calendar. So, and she's excited about this. So we will be partnering with OBGYN, I think in a very serious way. Third priority, again, expanding our addiction research to more translational. So Dr. Weintraub and his team has done a phenomenal job in providing clinical care, enormous amount of research or education going on, and some clinical research. What we're missing from the bed to bench is the bench to bed is the bench part. And so we did hire Majed Haraz, and Majed, you are here. There you are. Great. Welcome aboard. He's been on board for 14 days. Did you get your first RON yet? Did you hear about it yet? It's in, or it's going in October, right? Not first, but you're doing a great job so already. We need to collaborate with other scientists on this and other campuses. We have Dr. Asaf Keller in the audience from Anatomy and Neurobiology. Thank you for coming. We're really excited and we want to collaborate. We need to collaborate with other scientists. We need to be all inclusive in talking about science. And you guys have heard me say this probably 10 times or more. We need basic scientists sitting at the table with the clinicians, because that's when the ideas are generated. And if you separate and go into your silos, you don't advance as fast. You don't have all the information. You don't know what the clinicians are struggling with. You don't know what the basic scientists can do. And so we really need to bring them together. And one of our big initiatives that's rolling since last January is the RIC program, Research Integration into Clinical Practice. Mark Kavarda is co-chairing that with me. And we're setting up all of our clinical programs so that we act like an academic center through and through, rather than just here's our clinical programs, here's our research programs. And then we want to work with the School of Medicine to establish an addiction research center that Dr. Gladwin threw at me before he came through the door. So I'm just saying, more on that. And then of course, last but absolutely not least, another priority is for a new director for the MPRC. I'm not going to ask for questions because we don't have time. So I have the great pleasure of introducing our new Dean of the Medical School, Mark T. Gladwin. I thought about, this would be a brief introduction because I want to give you all the time to talk. But the most common questions that I have been asked by many of you is, where's he from and what's he done? So I looked at his 94-page CV. And it lays it all out very nicely. And it's fascinating, actually, his pathway. And so I encourage any of you or all of you to take a look at it if you want more detail. But I will start with, where's he from? So he did his undergraduate and graduate education at the University of Miami, Florida, did his internal medicine residency in Oregon, in Portland, Oregon Health Science University. He did a 1-year critical care fellow at the NIH following that, and then back to Oregon for a 2-year pulmonary critical care fellowship, and then back to the NIH for a senior research fellowship. Now in psychiatry, we call that ambivalence, just saying. However, he got it together And he stayed at the NIH for the next 7 years. So from 2001 to 2008, and many of you have asked me this, well, what did he do at the NIH? Okay, everything. So he remained at the NIH following a path of success, starting as an investigator and section head, moved to a senior investigator, then a branch chief, and then a director. In 2008, he then went to Pittsburgh and joined the Division of Pulmonary Allergy and Critical Care Medicine as a tenured division chief, established the University of Pittsburgh Medical Center Heart and Vascular Institute, and in 2008 became chair of the Department of Medicine, which I have to say has 750 faculty. Wouldn't have wanted that job. And that's a lot of faculty to manage. But he was, again, at the University of Pittsburgh, and the University of Pittsburgh Medical Center. Sound familiar? Just replace the Pittsburgh with, Maryland. We have the same arrangement here. What I found intriguing, and then I will hand over the podium, was he was also appointed to Associate Dean for Physician Scientist Mentoring and Associate Vice Chancellor for Science Strategy. His efforts focused in part to revitalize his department's clinical research programs with a focus on strategic growth and fiscal discipline. During his time in Pittsburgh, he successfully developed and recruited leadership in 15 new centers of excellence, which were designed to de-silo the faculty and bring basic science to the bedside, which I found very, very excited. He has a highly successful academic and administrative career. And if I've learned anything about Dr. Gladwin since before August 1, which was his start date, he has lots of energy, lots of ideas, and is a very strategic person. Please join me in welcoming Dr. Gladwin.
I have a cold, so, it's like the plague nowadays. So I'm trying to keep this to protect you guys. Thank you. Yep. Is that, okay. So if I just click, do I need to look at the camera? Is the camera right there?
It's right there.
So there's people in. Thank you.
Yep. And then you can use that.
Good. Thank you. Good. Well, thank you. What an impressive department. And thank you, Dr. Rockbeisel, for an incredible overview of the department. And I love how you call and out everybody's names and recognize everybody. It's very impressive. What she didn't mention is that I really do cherish working across the tripartite mission. So my whole career, I've been very active clinically, both in critical care, in pulmonary vascular disease, subspecialization, and in taking care of sickle cell patients with advanced lung disease. And for the 13 years I was at the NIH, every Wednesday morning, I went to the Howard Comprehensive Sickle Cell Clinic and took care of patients with sickle cell there. And I'll be speaking in 2 weeks at their 50th anniversary, recognizing Oswaldo Castro, who was my mentor there. But I've always been very engaged in clinical care and clinical research in sickle cell and in patients with pulmonary vascular disease. From an educational standpoint, I love teaching. Early in my career, I thought I was going to be a residency program director at Oregon Health Science University, but my chair of medicine at the time, Lynn Lorio, told me that to be a leader in academic medicine, I should experience a little research. And so I went to the NIH to learn cell and molecular biology from Oregon and fell in love with basic science research and translational research. So I ended up moving away from the med ed career to more of a physician scientist career. I am very active in research. My career, I focused on two fundamental discoveries. One is how redox chemistry, really, how the nitrite molecule reacts with hemoglobin to generate NO, nitric oxide, and how that can regulate hypoxic signaling. And the second area is how hemolysis during hemolytic disease like sickle cell releases sulfur hemoglobin, which scavenges nitric oxide and leads to vascular injury. And we do everything from basic biochemistry and chemistry to phase 2 clinical trials to dabble a little bit in outcomes. So I do really appreciate the master clinicians, master educators, fundamental scientists, translational scientists. I'm really agnostic to all science. I love all science. So I think you'll find that I respect what you do and appreciate what you do. So I wanted to go over what's forming as a mile-high strategic plan. And I apologize to some of you who have heard me say this before at our FBI leadership meeting, but I did want to share this with the faculty. And what I've really been focused on to start with is engagement. I have been coming to mini retreats with departments, with institutes, with centers. I've been traveling to visit hospitals, clinical programs. I've been meeting all the chairs in their offices so that I get mini tours and see where everybody works and what they do. So I've really been trying to spend an enormous amount of time engaging. I've been going out to dinner every night with foundation leaders, chairs, really trying to get to know people. But this is coming from the top down in a big institution like this. It's really a lot of memorization, learning, studying, and you all love these little abbreviations for DART and all these programs. So I'm doing my best to remember people and programs and places. So please bear with me. I am encouraging engagement. That as I've heard feedback from people, there's a common theme that people are hungry for engagement, that they don't necessarily want their leaders zooming in. So I think it is time to start crawling out from under the claws of COVID and be together as communities. I think it's better for mentoring, it's better for networking, especially for young people. And it drives team loyalty and stimulates team collaboration in science. So I'll be really pushing us to come together and engage, and all certainly be engaged. So, so first of all, we're going to be really focused in the dean's office and at the chair level and at the leadership level on a principle of faculty and staff first. And what we mean by that is our job is to support your creative energies and your clinical education and research success. So we really want to work to break down the barriers to your success. So we will start a challenging process of trying to increase the efficiency of the clinical trials system, the pre and post awards, the IACOCs. And this will be a work in progress, but our job is to make your life more efficient. We also really want to focus on and promote value-driven leadership. A commitment to the highest clinical, scientific, and educational standards, considering values in our business decisions, and of course, promote integrity in everything that we do. We want to have an inclusive, respectful workplace. That is going to be vital. And a big piece of that is really educating ourselves and confronting our own unconscious biases. And as part of this, I want to introduce Chris O'Donnell. If you could stand up, Chris, over there, and maybe say a few words. But Chris is just arrived 2 weeks ago as a new vice dean he'll tell me science strategy, but he'll tell you the exact title. But Chris and I have worked for 14 years together, and he's going to immediately double my bandwidth in terms of academic affairs. So I don't know, Chris, if you want to say a few words from over there. Actually, Chris, maybe there's so many people online, right? Why don't you come up here and just say a few words right up here, and then I'll.
Just speaking to you.
Yeah.
Hopefully you people out there in Cyberland can hear me. I'm going to answer the two questions of where is he from and what has he done. I have an accent, a New Zealand accent, even though I've lived in the States for 33 years. I left New Zealand, went to Cambridge to do my graduate studies, and then I was recruited to UCSF for postdoctoral work, actually by the former president of UMB, David Ramsey. I worked in his lab, which is sort of very ironic that I've ended up here myself. I got my first faculty position at Hopkins, and I was there for 13 years. And that's where I started a research career around the physiology of sleep. I've been in Pittsburgh for 18 years, 14 of them working side by side with Mark, and he's recruited me here. I'm very happy to be here. The second question, what has he done? I think probably the more relevant question is, what is he going to do? For me, I just want to express that I share sort of the values, the vision, and the passion that Mark has around academic medicine. I'm here to bring new energy, new ideas, work with you all. And I hope you find me attentive, receptive, and effective in what I can do for you. And lastly, I'll say I have a very passionate spot in my heart for psychiatry. When I was at Pitt, my closest collaborators were at WIPIC, Western Psychiatric Institute and Clinic. They have a very big sleep program. I worked with them, T32s, everything for years. And finally, my daughter is a resident in psychiatry at WIPIC after all these years. She was a bit upset that I left to come to Baltimore, but I really look forward to working with you all, and I'm really impressed by your academic success, and I hope I can help build that. Thank you.
Right. So one incredible opportunity that we have is to leverage this rarefied environment around us. I'm incredibly impressed that we have Northern Virginia, Washington, Baltimore, which is an incredible ecosystem, the political center of the universe, a population growth region, incredibly diverse. And we have so many major academic medical centers and systems. You know, Nova Fairfax, GW, Georgetown, NIST, ARPA, HHS, FDA, NIH, Howard University, Johns Hopkins University, and the list goes on. And if you think about that, we're the major public university in that rarefied environment. So I see an enormous opportunity for us to be elite, but not elitist as a public university, and to leverage those strengths. So I'm very involved already in leveraging those relationships. I have very long ties to the NIH. In fact, part of the reason I looked at this job and came here is my friends at the NIH pushed me. They said, oh, you've got to come to Maryland. And even a month before I came, we were in conversations with the NIH about developing physician scientist training collaborations here, about creating joint surgical programs with the intramural NIH. The intramural NIH has money, they have technology, but they don't have young people and they don't have patients. So there's a potential ideal partnership with them. We're also early on working with the FDA. I've had a meeting already with Rob Califf, who I know from the cardiovascular world, about how we can collaborate in real world data, real world evidence. I'm very interested in potential relationships with Hopkins, and have a dinner set up with the interim dean there, Ted DeWeese, who's also a friend of mine. And you know, I'm going to be very happy if we build programs, the NIH University of Maryland program in X, Y, or Z, the Hopkins University of Maryland program, because I see our competition as the University of California public schools and the University of Michigan and UNC, and then we take on Hopkins a little bit after that. I really believe in fundamental investment in people and their creative science, and that will always be a priority. I also think we have an opportunity to band together, as you are in the addiction space and the depression space and these other important areas, to tackle what I call generational challenges. And if you saw my interview here, I like to obsess about generational challenges. I'm impressed that at academic medical centers, and I tell all the students this, we're the luckiest people alive, because we are at the absolute front lines of confronting the things that matter, whether it's COVID or all the other zoonotic infections that are coming, monkeypox, SARS-CoV-1, Ebola, the list goes on, and it will continue in a highly populated, connected world. The emergence of antibiotic resistance, climate medicine with the movement of mosquito and tick-borne diseases north, whether it's the epidemic of addiction, the aging of our population and all the complexity of an aging population, the revolution in big data and disruptive computation, how that's going to affect healthcare and improve our ability to deliver healthcare. These are all enormous challenges. And so how do we align all that we have to take those challenges on, both the education, training people towards those challenges, whether it's science, you know, we're going to need fundamental science to break the curse of brain addiction, or whether it's training the best clinicians. So anyway, this is something that I'm thinking about and trying to mobilize foundations and resources towards these generational challenges. And we're going to be the people to do it at the University of Maryland, because this is the center of the political universe. And this city is confronting all of these challenges. It's red hot right here. So there's going to be some new initiatives rolling out very quickly. And I've already engaged Eric Weintraub and Dr. Reichbeisel and others in this. One is an addiction center. I think it's time that we have a school level addiction center that really leverages all the great things you're doing and generates more dollars towards research. And Chris pulled 12 search terms related to addiction, from opioids to withdrawal to alcohol and there were 40 million in yearly grants and 60 grants, federal and non-federal, already that we have here. And it's a diaspora. But most of the grants appear to be in the ID division and in the psychiatry department. So you are the leaders in this space. So I've made an ask to a foundation for 15 million and a promise to double that investment through space in BSF3 and money investment in building that space. We have shelled open space. And I really want to work with the Department of Anatomy and Neurobiology, Dr. Asaf, with your department, with the Division of ID and all the investigators around campus to invest in building research around addiction. And what I want to focus on are two things. One is fundamental research on how to reprocess neuronal signaling to try to reverse this addiction or ameliorate this addiction or prevent this addiction. So primary basic science, and then couple that to clinical research. And whether that's going to be embedded pragmatic trials, AI-based algorithms predict risk, whether it's going to be embedded pragmatic adaptive clinical trials through the EHR, we want to go from the bench to the bedside in this space. So that's going to be a big focus. I'm working very hard to get money to put into your hands. The second big initiative is going to be around computation and artificial intelligence. The Montgomery County wants to put some money into a computation center, and it would be matched by College Park, and this will be a partnership between the basic scientists at College Park in computation and our medical scientists here. Now, this will be a big initiative, and there'll be 4 goals. One is and it's going to all be focused around catapulting us to be a learning healthcare system, taking advantage of the electronic healthcare record data and turning that into population health and research. So right now, has invested 500 million in EPIC through all systems. That's the electronic healthcare record for the scientists in the room. And all of that data is now going to Columbia, to data warehouse. And that's being run by Warren D'Souza in collaboration with Steve Davis. And there's already shared research use agreements, there's de-identification programs, and there's strategies to get that data anonymized to the bedside. So using that data, we're going to invest more money in that to accelerate that process. And then we'll have 4 centers under this umbrella: real world data, real world evidence. Right now, the FDA is approving upwards of 40 drugs per year just on real world data, not traditional placebo-controlled trials. The second will be population health, reaching out through the EHR. Who's at risk of overdose? Whose creatinine's bumping and they're developing chronic kidney disease? Who has hypertension in pregnancies? What are those risk factors, and how do we reach out through the electronic healthcare record to try to bend that curve of health outcomes? The third is going to be embedded pragmatic adaptive clinical trials. This is the future of clinical trials, running research on the electronic healthcare record. I could talk about that later. The fourth is a College Park program, which is the augmented virtual reality of healthcare on the metaverse. So the idea that, this would be great for behavioral health, but the idea that you would put your video game apparatus on and you'd go into the health setting and see your data, interact with healthcare workers. I think things like this will be important as our population ages and it's more and more difficult to come to our tertiary care centers. I did spend an entire day at College Park. They're very eager. They rolled out the red carpet. They really value the School of Medicine, and they're hungry to collaborate with us. And one of the initiatives of Dr. Pines was Women Health Initiative. So he listed 4 priorities: this this AI computation program, women's health, gun violence. I forget the other one, but they're really committed, and we're going to be working to use and leverage those Empower dollars. Service to our community. There's no question, we are in West Baltimore, and we take care of the most vulnerable patients as inpatients. But when patients leave our hospitals, only 20% of our discharged patients in West Baltimore end up in our clinics. And that's the most vulnerable time, as you know, in terms of readmission, really putting a dent in disease, not just patching something up. So we've got to do better. And we have something now that Jill briefly mentioned, this upper payment limit. As faculty at the University of Maryland, we're now being paid for Medicaid payments, equivalent to commercial insurance rates. And the extra dollars from that are going into, one, these demonstration projects like HARP. There's a pediatric asthma program as well. And there's a diabetes program. Invest in that community. And then other dollars are coming back to you all based on the Medicaid billing that you do. So we can be paid well for doing the right thing. So we have to grow our services in the community. There's going to be a new development at the Mundawan Mall. Tim Regan, who used to be on our board, he is developing that and wants us to have clinics that engage our students. So student facilitated social work, nursing, medical students, clinics. And that's going to be a push for us. And of course, behavioral health is essential to the successful delivery of all healthcare. I also think that we should be investing in research programs that are relevant to the populations we serve. For example, we should have major investments in sickle cell disease research and clinical care, sarcoidosis, cancer screening in our African-American populations, and of course, advanced psychiatric care and women's child health. Both Chris and I have focused most of our administrative or leadership careers on physician scientist and PhD scientist development. And so I've been PI on 4 T32 training grants. I'm the PI I handed it over. I was the PI of the Burroughs Wellcome Physician Scientist Training Grant. And many of our T32s were focused on PhD investigators. Within our Department of Medicine, we had 120 PhD investigators. 168 PhD investigators. We had a PhD community, and we heavily built team science between MDs, MD PhDs, and PhD investigators. And right now, we had 13 T32s by the time we left the Department of Medicine. Pittsburgh, right now, we have 13 T32s in the entire School of Medicine. So this is a big opportunity for us. But one thing is that as PIs, you don't get much support to lead a T32. So we're going to start supporting 10% effort for T32 program directors. We're going to look at other incentives, but it's vital that we develop a rich tapestry of T32s. And we've been very excited about what we call the T to F to K to R to U to P pathway. And at Pittsburgh, we had 54 career development awardees in the Department of Medicine alone. And we leveraged CDAs from the VA, K awards, foundation awards. And so it's delightful to hear that you have 5 Ks in the department. It's wonderful. And we want to create a network of our K awardees so that I can also get to meet them on a regular basis. The other thing we have here that's really unusual is the remarkable set of grants that are supporting and recruiting elite URM physicians and scientists. So we have the CURE program through the NCI, taking care of young children in West Baltimore and advancing them to STEM careers. We have the UMBC STEM program, which is elite. We have a new T32 that Dudley Strickland just got for URM PhD students, grad students. And this week we got the formal notice of award that Jim Caper is PI. We got the first award. First award's incredibly competitive. Hopkins doesn't have it. Pitt didn't have it. Vanderbilt doesn't have it. And it's 10 slots, 600,000 per slot to recruit URM faculty that are early career. So superstars with Ks, K to Rs, and 2 of the slots are in neuroscience. So I think there's a real opportunity. We are a Black city, and we can attract the most elite, diverse scientists. And that's going to be a focus of mine and an interest of mine. Turning to clinical, I love data, and I feel that you can't really manage change or understand where you are without really having data. So I am going to be asking for a lot of data. And I just say this because it's not to micromanage. You'll feel like you're being micromanaged. And it's not focusing or picking on any one person, but I'm impressed that we don't have the data we need to improve the efficiency of what we do. And what do I mean by data? So inpatient metrics, work RVU per CFTE, shifts, density of work per shifts, shift census, shift hours. These are basic metrics of inpatient productivity. Research metrics, dollars per square foot, number of grants, grant density, federal, non-federal funding. I think we're pretty good about collecting that data. Outpatient metrics. Outpatient metrics could be time-based metrics, how many sessions of clinic, how many hours per session, what's the new to return ratio, what's the 24, 48 hour no-show late cancellation rate, what's the time for new, time for return, what are national metrics and standards. This is data that we need. Now, why do we want this data? Number one, it's an opportunity to increase efficiency and revenue, and I'll come to why that matters. But the second is we make a case every year to the hospital that we need their support. And we need data to defend our staffing support models. And that's a big part of me. My job for you is meeting every week with Mohan Suntha and Bert O'Malley and saying, hey, you guys are the best physicians in the world. We're efficient. We need support. And so I'll want that data. Access, access, access. The future of medicine is moving out of the hospital. We are a hospital-bound practice plan. You have a lot of clinics, so it's great to see that. But if you look at the weight of what we do in most of our departments, it's very inpatient-centric. But if you look at Medicare billing data, it's just all going outpatient. Inpatient bed use is dropping nationally. Even across the systems, there's concerns that the inpatient beds are lower and lower acuity. So we really have to be moving to outpatient care. And everybody, all our competitors are way ahead of us right now. Kaiser's out there, Hopkins is out there, Washington Hospital Center's out there. We are the major public academic medical center, and we have to compete in this future world. So we have to move to outpatient medicine. And that was a very big push of mine at Pittsburgh. We went from 62 days for an average call to see as a new patient to under 7 days within 6 months. We did it with telemedicine. We did it with expanding advanced practice providers. We did it with a lot of strategies. So I'll be talking about that a lot. I also want us to develop independence from the hospital. Right now, a big chunk of our revenue comes from transfer dollars from the hospital through PSC. I would like FPI. This is a chair-run practice plan. Most practice plans are now owned by hospitals and systems. One reason I'm here is we, physician leaders, you all lead your practice plan. And so we want that to be viable and generate revenue to support our mission, which we cherish. And so I want some independence from the hospital. We're going to do that in the unregulated outpatient environment. We need to diversify our payer mix. We've got the upper payment limit, which is great, but we need to capture volume and revenue in areas like Howard County around us, et cetera. We have a lot of advantages here. There's money from the Senate called Senate Bill 433 for us to build practice groups. We have that investments in things like Medalwin. I told you we have the upper payment limit. We have our own practices in Waterloo, but we have to grow those and succeed. I think we should look at our comp models. Are our comp models transparent? Are they giving the right incentives for volume and value? And so these are things, we'll think about and look at, but really engage you. This will be an engaged process. Don't mistake that my number one goal is to generate a margin to 100% invest in the academic mission. And that academic mission is medical education, elite clinical programs of excellence in research. So we want to increase our marginal revenues to invest in research. And a great thing about our University of Maryland system is we get 20% of the budgeted margin from UMMC right into supporting us. We get major hospital support from the hospital. And also we have margin, we own the practice plan. Any margin we generate in the practice plan goes to your department, goes to the dean's office, and you'll see that I'll invest that back into you, just like I am with this addiction center. So, but I'm going to be very focused in the next 3 years at how can I ramp up that margin so that in 3 years we are flushed with money to build the academic mission. So it's a reality, but it's something that I've been good at, is building clinical revenue generating programs that then support what you all do. The other thing we have to tackle to this end is value-based payments. There's $80 million of additional money on the table if we can improve the quality and value of care at UMMC. 80 million a year, and the hospital is willing to share that with us. So we're really going to be working on getting our US News, Leapfrog, CMS, Vizient rankings higher. And I know you're already involved in that, and we seem to be on the right track. We need to look at extenders or advanced practice providers. At Pittsburgh, by the time I left, we had approaching 800 faculty, but we had 200 nurse practitioners. We were hiring 50 per year when I left. Most areas of medicine now, you can't hire or train physicians fast enough to meet the population health outpatient need. And unfortunately, as physicians, we're too expensive to provide outpatient need. We don't cover our salaries on E&M pro fee billing. The best thing are partnerships between advanced practice providers and physicians. But we can do that in a way where the physicians benefit, where we have incentive plans for that partnership and we work as teams. And I'll be sharing those models with your chairs. I know at Western Psych, I want to learn from you all how behavioral health experts work in the psychiatric environment. At Western Psych, every clinic had embedded behavioral health. All our primary care clinics had behavioral health specialists. And they said that. I did a big debrief before I came here with our extensive network of primary care, 340 sites. And they say they make money on behavioral health and it dramatically improves health outcomes. So we should explore these kind of things. But again, there's a lot to learn about. And finally, excellence. You know, as I said, I love education. I love clinical care. I love research. And all three pieces of this mission are going to be valued. And there's going to be certain groups of us that work in one domain or the other. And I just want us all to be the best at our domain. We don't have to be the best at everything, but the best at our domain. And we also want to recognize your excellence. I know right now some of the metrics, for example, for promotion and tenure have been somewhat numerical, like the number of papers. I think we'd like to be more aspirational. We need to value the impact of the work, not necessarily the impact factor, but the value of the work. There's also new forms of publication, you know, online media, podcasts. Those are very important. There's important missions that we are part of that directed at health equity, social justice. Those things should be valued. We also do have to appreciate that the COVID pandemic was extremely disruptive to people that are caregivers, whether children or parents that you all are caring for. There's clear data that women have been disproportionately impacted in terms of productivity by the COVID pandemic. So we're going to recognize that and understand that, and we're going to want to hear feedback from you. You know, we still have to have I want to make sure that if you're a full professor at the University of Maryland School of Medicine, that is an elite honor. It doesn't matter whether it's tenure track or non-tenure track. To be a full professor, that's an elite honor. It's an elite honor to be a tenured associate professor. We're going to value everybody's promotion and contribution, but we do want to have a broader view of the work that you all do and a broader appreciation of that work. That's it. I'm going to stop there, and I'm happy to take questions, thoughts. I didn't mention much about the med school because the med school is so impressive that I think my job is just get out of the way. Our med school, we had 6,000 applicants for 145 seats, 70% women, 80% in-state, 30% URM, 60% self-identified persons of color. Scores are the highest they've ever been. I've been meeting all of our alumni and our foundations. People are incredibly proud to have trained at the University of Maryland. It's probably our greatest strength is our alumni and that pride, and the med school, which is the core, kind of feeds our core values. So I'm going to want to see us develop those pathways from the med school, from our advanced degree programs, to our residencies, to our fellowships. Sometimes we can let people leave, but we'll expect them to come back. So I'll stop there and see if anybody has any feedback, questions, thoughts. Thank you. It is intimidating talking to psychiatrists. I have all sorts of disorders, as Chris will tell you. First thing I learned in psychiatry is you just allow silence to develop, right? And then people ask questions. What did I miss? Great. Yeah, the comment is other centers where we could partner with the NIH. Yeah, if you have the names of those, let me know. Yeah, there's a new head of the surgical oncology branch, for example. I think we could have a real opportunity to be the site for faculty contracting and partnerships and training partnerships with the NIH. So any ideas you have for those collaborations, we are in pretty much constant communication right now with the NIH. Other thoughts? I should have mentioned that. Great question. What's my views of industry academic relationships? So first of all, I've always been in the drug development space. So while I was at the NIH, we patented nitrite as a human therapeutic, which is still in phase 2 trials now. And I've developed a whole class of carbon monoxide poisoning antidotes. And so we have a startup company called Globin Solutions. And when I was at Pittsburgh, I was co-chaired a committee that put together a white paper on how to enhance University of Pittsburgh's entrepreneurship. And part of the reason I was so excited about coming here is your biopark and that incredible program to leverage and develop kind of homegrown IP and translate that. A lot of our board is very committed to this. So I've recruited a young associate dean named Jason Rose, who came last week, and he's going to report to me as well as to Jim Hughes. So we'll have more communication across biopark and the School of Medicine. And Jason has a entrepreneurial MBA from CMU. He writes STTRs, DOD, but he's an expert in startup companies. So we're very interested in obviously maintaining the rigor of human subjects protections and having conflict of interest oversight, but making it easy to start companies. In fact, I think this could be a calling card for us, where you come to the biopark as a faculty, and you might be part-time faculty, but you're building a company. It could be a way that we could bring in additional revenue for research. I don't know if you heard, Wexford is in the company. Wexford's from Baltimore. They build all the big labs across the country, and they just got approval. They're going to break ground anytime now with a new 250,000 square foot glass building right on MLK. And that firehouse is going to become a restaurant. And that is supposed to go up in the next 2 years. And we have 60,000 anchor space there. And that's subsidized space. Well, there is rent there, but it would be subsidized for startup companies. We might put some programs there. We even have been looking at MPRC there. I'm surprised there's no MPRC questions, but that'll be later because I'll visit there for an entire day. I am going to go for a whole day to MPRC. Oh. Oh, I'm a little dense. Yeah. Yes. Yeah. Yeah, Jim Capers brought that up, and Chris, Chris Priority knows more about that. But yeah, there's this metric that that Dean Reese had monitored about number of grants per department. So yeah, I think you always have to be careful with measurement. You know, I said data, 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 but it's like Heisenberg uncertainty principle. If you measure something, you change its course and location. So the measurement process itself can have unintended consequences. So I think we definitely want collaborative science. And so we need to fix that. The other thing we have is this drift dollars. And my understanding is that, if you look at our basic science portfolio, it's incredibly strong. Some of our clinical departments are not as strong in NIH funded research. And most of the research in that clinical department is occurring in the basic science department. So we need to think about that. Cardiology, for example, we don't have many cardiology grants, yet NHLBI is a huge piece of NIH funding. Most of our cardiovascular research is in Dudley Strickland's operation in the physiology department. So we need to think about how can we strengthen for example, the Brain Institute. I've already had discussions. My chairs, including you, are willing to put money into the Brain Institute to recruit, but they don't want to recruit into the Institute and then the Department of Psychiatry doesn't get any indirect drift funds and doesn't get any credit. So I've already talked to Chris about coming up with a strategy where maybe we up the drift funds for certain major initiatives and they're split. So someone could be, maybe in the Brain Institute and in psychiatry, but the drift funds would be increased and shared. As long as we're spending the money on growing research, it doesn't matter whether it comes to me or goes to you. So we're going to be looking at that. But I agree with you. We need to look at any things that are unintended breaks on partnership, collaboration, productivity. Addiction, there's so much money. This is like the beginning of the AIDS epidemic. Money is going to pour into the space. So, we want to be a NIDA hub. We need to really grow addiction research. And there's big collaborative money. And I think this addiction center can get a lot of people's attention. So I think I've heard complaints from some of the clinical departments like neurology that they struggle to recruit people in neurodegeneration. We have the GREC at the VA. That's 12 slots. That's a lot of money. We have our neuroscience department. We have to synergize and then put it in an environment. So when we bring a recruit in, they say there's so much neurodegeneration going on here that I want to come here. So I'll tell you one story. When I went to Pittsburgh, I was tasked with building the Vascular Medicine Institute and with leading the pulmonary division. And about 10 years ago, cardiology research fell apart at Pitt. There was a fight over a service line. And Barry London, the division chief, went to Iowa. He took 2 of his research with it. Essentially, all research died in cardiology. And there was a huge clinical service line, huge, 240 cardiologists, really most of Western Central PAs under the cardiology service line. Well, they tried to recruit a division chief, and no academic division chief would come because they didn't control the service line. And so then the head of the hospital said, Mark, why don't you be the division chief of cardiology? Because I had this institute. And I said, you can't have a lung doctor be a cardiology division chief. That just is not culturally acceptable. And I said, but I could be the scientific director and then have the service line director as the division chief. So June Lee became the division chief and I became the scientific director. And when I went around, I met with all the faculty and they said, we can't recruit anybody because there's no cardiology research environment here. So what I did in the first 2 weeks is I took the Vascular Medicine Institute website and I just put it on the research tab of the cardiology division. And then when everybody came, I said, check out our website, all the science. And then I toured them to meet the PIs in the Vascular Medicine Institute. And it was like a week later, I remember people telling me, you have the best cardiovascular research scientific environment. And we now have 20 R-funded cardiologists. So physician scientists. So I mean, so I think we can do the same thing in brain, addiction. It's an alignment creating this ecosystem. And then suddenly it's the place to be. Anything else? Yes. At WIPIC or WIPIC? Yes, I was on your advisory committee. Good. Yes. First, tell me why. Tell me why is it hard to make money and have those relationships? Yes. Yes. So very eloquent. I'm gonna have to watch out for my job with you. And you really brought up two issues. One is the critical importance of humanism in what we do as physicians, but also as scientists. And the next generation, I'm really impressed. You know, people like to say, back when I was a resident, I'd walk barefoot up the hill in the snow on call every other night. And the new generation doesn't do this, doesn't do that. But I'll tell you, this new generation, we have one of the largest residencies in internal medicine in Pittsburgh. The new generation is very committed to value-driven medicine. There's a really high interest in palliative care, in global health, in health equity, in climate medicine, and in psychiatry. You're seeing the data. Psychiatry interest, you know, Chris's daughter is super competitive to get into WIPIC. So it's changing now. And I think it's two things. I think it's the commitment to humanism, but also the explosion in brain research, where finally we have tools. And I would say these are not mutually exclusive. If you look at William Osler, I just read his biography, and he was feverishly focused on mechanism disease. He did autopsy on every patient that he could get his hands on, but he spent hours at the bedside and he had no treatments. He was the most appreciated physician. People paid arms and legs for him to be their doctor when he had no treatments. Mostly he diagnosed, he gave a prognosis. He might offer some palliation. But that mixture of a commitment to understanding biology and science, but humanism, is something that we hope to strive for. So I appreciate that. There is a business side of the equation, though, that you mentioned. The business side is the demand for mental health and psychiatry is off the charts. We are now becoming enlightened in academic medicine. You know the data, 4% of patients are 70% of the costs. That 4%, they have inordinate amount of substance use disorder, PTSD, mental health issues. 52% of most hospital inpatients are on a prescription opioid. And the only way you're going to bend the curve of health is with behavioral health, no question. And we've now destigmatized behavioral health. You know, my daughter, who's at Reed College, wants to see her therapist every week. Our medical students are so open to seeing therapists for therapy for their anxieties, and they're an enlightened, new generation, which puts more of a need. So how do we meet this massive need for behavioral health? So one is we've got to get rates up. You know, this is one of the most important interventions. So behavioral health and behavioral therapy has to be reimbursed higher. And we're at the political center of the universe. We need to probably work together. But the second thing is we have to embrace advanced practice providers, that we have to leverage social work, et cetera. So I think we've got to be very strategic about this. I also think maybe there's opportunities for hybrid work where there is, out-of-pocket for-profit work that some of our faculty do. I don't know. I have to learn more about this. At Pittsburgh, I know that in Pittsburgh, if you want to see a child psychiatrist, if you want to see a psychiatrist, you can't even get in to see them unless you're paying out of pocket, unless you go through WIPIC. And don't forget that we're the place of last hope. We are the front lines. So the wealthy people can get access somehow for some dollar amount of money through telehealth or whatever, but we're providing that humanistic service at the front lines. So anyway, I hope you've heard from me how much I value what you all do and your profession and the brain and psychiatry. And thanks for hearing me for so long. Thanks.